So in this session, we're going to talk about the pharmacology that's involved for the specialty care transport paramedic, specifically at our local level. The previous two portions that you've watched talk about pharmacology in general and some of the different categories of medications and how we should handle them. However, for today's program, we're going to look into the actual categories that we have available. Each state and each regulatory body has a specific formulary, which is the official list that gives a detail of what drugs or medicines can be prescribed. Our paramedic formulary is the drugs that are typically carried and administered by an average paramedic, so epinephrine, atropine, glucose. The specialty care formulary looks at those medications that the average paramedic is not usually trained on, nor do they consider it. So it's for paramedics to transport a patient who's already had a medication initiated. We have a large number of categories of medication, and in this lecture we're going to go over the specific ones that are approved for transport in Connecticut. We'll look at the difference between some drugs that fall into more than one category. We'll look at what category is carried on board a normal paramedic unit and which ones have to utilize an SCT paramedic. Our first one is analgesics, so painkillers. The average paramedic and those in the Stanford region are authorized to carry fentanyl and morphine, and SCT medics are approved to carry the others that you see there. Specifically, two of them, ketamine and ketorolac, are different types of medication, as is nitrous oxide. The others are all opiates. So we look at the list of opiates, which stimulate the opiate receptors in the brain and in the body and cause altered mental status, respiratory depression, and specifically pain control. And those include fentanyl, morphine, Dilaudid, Demerol, and Nubain. We should note that in Connecticut, fentanyl, morphine, and Dilaudid are all approved paramedic medications. However, in our local area, Dilaudid is considered an SCT drug because it's not part of our routine formulary. There's a theory called equinalgesic, I can't say it either, equinalgesic, which is a comparison of the pain relief of certain medications to 1 equivalent milligram of orally administered morphine. So if you took 1 milligram of morphine, how much aspirin would it take to cause that much pain control, or how much fentanyl? This looks at a straight number. It does not consider the side effects of a medication, the bioavailability, which is to say how much drug actually gets into the cells that it needs to, or the half-life of the drug. So this is a very simple consideration. It was initially used when morphine was the baseline drug for pain control, and as new drugs came available, when physicians were switching patients over, they would consider the equality. So if we look at morphine, 1 milligram in the middle as an oral medication, we can see that if we go to a stronger, or down this triangle, IV morphine is about 3 times as effective. So for every 3 milligrams that you give PO, it's equal to 1 IV. Methadone is actually stronger than that. We get up to heroin and ultimately fentanyl, which is 50 to 100 times stronger than PO morphine. When we go the other way, hydrocodone, codeine, and tramadol are less strong than morphine, and then down into the other category, which is naproxen, ibuprofen, and aspirin, which are actually NSAIDs, non-steroidal anti-inflammatories, which don't have the same opiate effect, but do reduce pain. Conveniently, ibuprofen, naproxen, and aspirin also have fever-reducing capabilities. So Toradol, also known as ketorolac, is an IV medication. It can also be given IM, intramuscularly, and it's good for longer-term musculoskeletal pain, also frequently used for kidney problems. Some paramedics do carry that. The Middlesex Hospital medics carry Toradol currently. Additionally, the SCT medic is approved to transport a patient who's already been placed on nitrous oxide, which actually has an interesting effect that it stimulates the internal opioid receptors and releases the endorphins in the body. So it's actually causing you to relieve your own pain. The next category we talk about is anti-anginals or anti-anginals. Anti-anginals are drugs that relieve chest pain that's caused by cardiac problems. So typically we see that these are nitrates. Sometimes beta blockers and calcium channel blockers are used as a precursor to reduce the effects of angina. So this is usually caused by coronary syndromes. All nitrates So nitroglycerin, IV nitroglycerin, PO by paste or by patch are all considered to be standard paramedic level care, and they act as vasodilators. The paramedic needs to watch out for hypotension, especially in case of a runaway IV. IV medications like this should always be given by a pump and not just run wide open. Obviously, with nitro paste, we have the risk that by the time it starts absorbing transdermally, the drug is in the system and we can't take it back. With PO or IV, we can stop administering it quickly, which is a little bit easier to control. Our next category of medications that are carried either by the paramedic or transported by the SCT medic are antiarrhythmics. A routine paramedic carries a collection of antiarrhythmics, and we're looking at these drugs for their cardiac effect, even though some of them have other effects like lidocaine and mag sulfate. But the average paramedic will carry adenosine, amiodarone, atropine, lidocaine, mag sulfate, and percanamide. Those are considered routine ALS, whether they're being given in a bolus form or a maintenance IV, whether initiated in the field or in the hospital. So that's a standard ALS transport. However, the SCT medic is required when specific medications are given. Now, even though some calcium channel blockers and beta blockers are initiated as field medicine, all the others are treated as an SCT drug. In addition, digoxin, isoproterenol, and Corvert is considered an SCT level medication. Isoproterenol specifically is an adrenaline or epinephrine-like drug that works in the body in much the same way as adrenaline. While in some areas antibiotics are routinely transported by paramedics, because they are not part of the standard formulary, they should be considered as SCT level. So antibiotics running in an IV will be considered SCT. And our primary concerns with these is not the effect of the antibiotic, but any untoward or side effects. So there could be IV infiltration or an allergic reaction. And in general, our reaction to any antibiotic problem is to discontinue administration and then treat the patient using our usual allergic reaction protocols or anaphylaxis if needed. Typically, this is going to be a patient who's going from point A to point B and they need rapid antibiotic therapy. It might be in conjunction with care for septic shock. Our next category of drug is anticoagulants. And we need to remember that anticoagulants are different from thrombolytics. Anticoagulants will prevent future coagulation of blood, but they don't reverse existing blood clots. So these are used for prevention of further damage in the body, not for reversal of existing damage. The primary risk factors that we see with anticoagulant therapy is increased bleeding, specifically post-surgical bleeding. So if a patient has had recent surgery, these may be contraindicated or they may have to be delicately balanced. They can reduce the effect of atrial fibrillation, coronary artery disease, deep vein thrombosis, myocardial infarction or heart attack, pulmonary embolism, or restenosis, which is when a patient has had a stent placed in a blood vessel and it becomes stenotic again. So there's a rebuild up or calcification within the blood vessel. When we look at the different categories of anticoagulants, one of them stands out. They're called NOACs, or novel oral anticoagulants. And the one that we see advertised right now is Pradaxa. There is a reversal agent for this, and that is called Praxbind. This is a great drug because it has a rapid onset, it's very controllable, it has a short half-life, and it needs very little monitoring. Because a routine paramedic doesn't carry this, it is considered an SCT level medication. Antiplatelets, again, are not thrombolytics, but they prevent further coagulation. And the one that everybody knows about is aspirin, which can be administered PO or IV. When it's given PO, obviously the patient's already taken it, and it's no longer a paramedic concern. However, if it's administered IV, we do consider that to be an SCT level medication. Plavix is routinely administered orally. However, if it is given IV, we will transport it as an SCT medication. So what this does, both the aspirin and the Plavix, they work in similar ways. They inhibit an ADP chemoreceptor in the cell membrane, and that receptor, which we're inhibiting, causes activation of platelets and fibrin linking. So if we don't have the activation of the platelets and the fibrin causing the links, then we don't get more clots. So this will prevent any further clotting. However, we'll look to thrombolytics in a little bit to break up the existing ones. Within the category, we look at coumarins, which sounds like Coumadin. Coumadin is a coumarin, and it's a category of medication, including warfarin, which is derived from plants, and it is actually the same as rat poison. However, rat poison clearly is in a much higher dose. Vitamin K is part of our clotting factors, and this reduces the actions of vitamin K. The good news about Coumadin or warfarin is that it can be reversed with a vitamin K infusion if there's an overdose of warfarin. Heparin brings us into another category, and this activates antithrombin 3, which blocks the thrombin from clotting the blood. So here we actually have a blocking agent. Heparin comes from pig intestines, and you may see on transfer paperwork that the heparin that was administered to the patient was porcine or pork-based. They actually make it from the intestines, and you can see on the screen a picture of a fellow preparing the intestines. Specifically, low molecular weight heparin is useful for certain types of treatment, and I believe it has fewer side effects. Lovenox and Fragmin are two of those. So for the purposes of SCT, all paramedics, SCT or routine paramedics, may transport a patient on heparin and Lovenox. However, all of the other anticoagulants are considered SCT medications. One of the side effects of heparin is thrombocytopenia, or specifically HIT, heparin-induced thrombocytopenia, which is an immunological response against the platelets within the body. It'll cause a low platelet count, and here we see an example of some petechiae that would be an evidence of this. If you saw this occurring, it would be a good reason to consult the sending physician about adjusting the heparin dose. Our next category of medication is the anticonvulsants. And what you'll notice is that some of these drugs pop up later under sedatives because the benzodiazepines have multiple uses in our practice. A routine paramedic can transport a patient getting an IV infusion of Valium, Ativan, or Versed, as these are usually carried in the field. However, a patient being given Dilantin or Tegretol would have to be transported by SCT paramedic. Dilantin, which is also called Phentoin, it prevents tonic-clonic and partial seizures, but doesn't do anything about absence seizures. So usually after a patient has been refractory to benzodiazepines, they'll attempt a Dilantin infusion. This also has a couple of other uses, including treatment for neuroleptic pain, so pain that doesn't respond well to other therapy. This drug works by blocking sodium channels and therefore increasing the threshold of seizure activity. There's two common antidotes or antidotal drugs that we see used in EMS and in the emergency department, one of which we carry and is now a BLS medication, that's Narcan. So that's acceptable for routine paramedic transport if it's going IV. However, Romazicon or flumazenil, which if I recall is also a test question for the state, is a drug used to reverse the effects of benzodiazepines. They work differently though. Whereas Narcan gets into the opiate receptors, Romazicon works differently and it has a much different time frame. Narcan usually works within seconds when given IV and within several minutes when given nasally. Romazicon takes a little bit longer, as much as several minutes to 30 minutes to work. With both of these antidotes, the paramedic has to be concerned that we may have to redose the antidote because the opiate or the benzo often has a longer half-life than the antidote drug. So we may end up having to increase or repeat dose either one of these. Antiemetics are drugs that reduce the patient's desire to vomit. They reduce nausea at the brain level. Several of these are approved by the state to be carried by paramedics. However, for the Stamford area, only Zofran is considered a regular medication for all paramedics. Phenergan and Raglan are considered SCT. Phenergan specifically is actually an antihistamine, and it has some sedative properties and anticholinergic properties. So it will work an awful lot like Benadryl, and will make your patient drowsy. Antihypertensive medications include drugs that do different things with the end goal of reducing the blood pressure. These are great for hypertensive crises and sometimes with head injuries or strokes. However, most physicians will be careful to keep the mean arterial pressure, the MAP, at a high enough level so that perfusion to the brain continues to occur. Because we don't want to drop the blood pressure so low that whatever is blocking the blood flow in the brain is not overcome by perfusion. So the antihypertensive include beta blockers, calcium channel blockers, and ACE inhibitors. When they're administered for this purpose through the IV, they're considered SCT level. But then additional drugs that we don't typically see, including clonidine, nipride, and hydralazine, are all considered SCT medications. Clonidine decreases peripheral vascular resistance. Nipride is a specific vasodilator, and hydralazine is an arterial vasodilator. So it actually will decrease the afterload on the heart without causing as much effect on the preload. A couple of obstetrical medications that we see, and again, mag sulfate pops up because it's used for so many different purposes. Our regular ALS paramedic can transport a patient on mag sulfate or oxytocin or pitocin. Those are considered within our normal formulary. However, the SCT medic will cover the other drugs. Metherine and terbutaline are two drugs that are transported. It's actually methergine. I have a spelling error there. And terbutaline are two drugs used for OB patients. Specifically, terbutaline is a tocolytic. It stops or reduces contractions. So terbutaline will delay labor by 48 to 72 hours, often used for preterm labor, and it allows time for steroids to be administered to the mother so that the fetal lung can mature prior to birth. Conveniently, this also has the other use of being a bronchodilator. We'll see it pop up under respiratory meds in just a moment. Methergine is a smooth muscle constrictor. So it's used for a different purpose entirely. It works directly on the uterus, or mostly on the uterus, and it causes the uterus to tighten up. And this causes two things to happen. One is it can cause contraction-like expulsion of an aborted fetus. So if there was a miscarriage and the products of conception had not yet been delivered, this will encourage that to happen. Also, the tightening of the uterus will decrease excessive bleeding after childbirth. So if we're taking a person after childbirth for critical care, they may be receiving this medication. Most of the bronchodilators are considered routine ALS medications because we carry them in the field, whether it be albuterol, levoalbuterol, which is called Xopenex, epinephrine, or ipratropium. These are all considered routine ALS medications. There are two, however, specifically that are considered SCT medications in our area, and they include neosynephrine, which is essentially phenylephrine, which is a vasoconstrictor, and a nasal decongestant also. You can buy it over the counter, and aminophylline. Diuretics may be used to reduce cranial pressure. They may also be used to reduce fluid buildup in heart failure. Two of those medications are Bumex and Lasix, which are considered to be routine paramedic drugs. Up until recently, most paramedics carried Lasix, and they're loop diuretics that work in the kidney, in a loop of Heine, to draw extra fluid off of the body. We frequently see mannitol used with head injuries, and it's actually a sugar alcohol. It's the same stuff that we find in sugar-free candy. It's the same kind of sweetener. This is an SCT transporting drug, and it draws the water out of the cells to reduce the amount of fluid that's in a contained area. This is the same stuff that if you eat too much of it will cause diarrhea. You can see that it causes fluid transfer. Several electrolytes fall under the routine ALS transport, and that's calcium chloride, mag sulfate, and sodium bicarb. Three drugs that we carry on a regular basis that any paramedic can transport. Potassium chloride, which is specifically used to elevate the potassium level, is also a typical medication administered in the hospital. It's given by IV infusion. It appears just like saline, and it often comes in 1,000 bags. However, it is considered to be an SCT drug because it's not routinely carried. When we look at endocrines, it's external administration of an endocrine that is normally found within the body. So three typical ones, glucagon, pitocin, and vasopressin, can be administered by a routine paramedic. However, insulin is considered to be a SCT medication. If insulin is administered subcutaneously, at the hospital, and then the patient is transported. There's no SCT requirement. However, if it's given as an IV drip, we'll be monitoring it at the SCT level. Octreotide is an interesting medication that causes a reduction in the hemorrhage of esophageal varices. When we look at neuromuscular blockades, these are the paralytics. And one big note we need to make about paralytics is that paralytics, while they stop movement of the body and they reduce all function, they do not do anything to the patient's level of consciousness or awareness, and it does not control their pain. So it's absolutely essential that anytime a patient is receiving a neuromuscular blockade or a paralytic, that we also accompany this with some sort of a sedative or hypnotic and pain control. So in our area, the average paramedic is allowed to transport a patient with rocuronium or sux running, because these are both part of our standard protocol. Tarcrium, vecuronium, and Nimbex are 3 drugs that are considered to be at the SCT level, and we'll be transmitting those patients on an IV pump. One category that seems like a low-risk drug, but it turns out it actually has a high level of risk, is parenteral nutrition. Because we carry thiamine in the field, which is essentially vitamin B1, we can transport that at the regular ALS level. However, all other IV nutrition, and note that this is not through a PEG tube or a G tube, this is IV nutrition, is at the SCT level. So whether it's multivitamins like a banana bag, total or partial parenteral nutrition, these are SCT. PPN and TPN is a IV concoction that essentially provides the patient with all of their carbohydrates, fats, proteins, and other nutrition and vitamins directly through the veins without any use of the GI system. So it's really good for people who have GI problems and the intestines aren't functional. It gives it full rest. However, there is a high risk of infection with this because it requires a central line access. There's a risk of blood clots and actually liver failure because of an excessive amount of lipids and fats put into the body. Phosphodiesterase 3 inhibitors, or PDE3 inhibitors, are medications similar to Viagra. Every one of these is considered SCT level. The one that we see the most is milrinone, very common. The others are listed there too. These are great drugs for heart failure patients because they both cause vasodilation, reducing the preload on the heart, and also increased function or entropy of the heart muscle itself. So they cause the heart to work stronger and reduces the back pressure on it. We talked earlier about benzodiazepines, we talked about paralytics, but our sedative hypnotics are really the ones that take out a person's mental status. They reduce them to very low functioning or unconscious entirely. Our basic paramedic level transport medications include etomidate, Haldol, lorazepam, midazolam, and diazepam, because these are all commonly carried medications. However, in the Stanford region, ketamine and propofol are both considered SCT medications. Now, in the Bridgeport region, ketamine is considered an ALS drug and it's used for excited delirium. However, when we're transporting through the SCT program in Stanford, this would be an SCT drug. Specifically, propofol, which is a white-colored fat-soluble lipid, it's a fat-based drug, is usually given in a maintenance dose that we'll transport the patient on, and then the physician will usually give us an order for a push dose in case the patient regains consciousness or becomes agitated, so we can give them an extra couple milligrams along the way. Methylprednisolone is our routine ALS medication. However, any other steroids that are given by the IV, depomedrol, dex, hydrocortisone, or prednisolone, are all SCT paramedic medications. One interesting medication that we rarely transport, but may have to for patients either with CVA or MIs, are the thrombolytics or clot-busting drugs. And every one of these, regardless of name, is considered an SCT medication. Alteplase, Retaplase, Tenecteplase are some of the name brands. These are tissue plasminogen activators, and they're usually recumbent, so they come in 2 different bottles. So it's a water, kind of like a glucagon, where the water and the powder gets mixed, and then it gets administered over a time period. Our primary concern with this, other than local infiltration, is systemic bleeding. especially if the patient has had a recent surgery that maybe wasn't brought up in their history. The two vasopressors that are considered routine ALS include dopamine and epinephrine because they're routinely given in the field. One addition to this may soon be Levophed or norepinephrine because dopamine will no longer be a field drug. However, we will have epinephrine and norepinephrine or Levophed as a routine ALS medication. Patients who are on vasopressor therapy, usually treated because they have hypotension, will get phenylephrine, pitressin, dobutamine, or isoproterenol. We do have to watch for excessive hypertension with an overdose of these medications. When we look at the category of volume expanders, this categorizes two different types of drug therapy. The most simple one is all your crystalloid solutions, so your normal saline, your Ringer's lactate, your D5. Those are all considered paramedic level, whether they're on a pump or not. However, specific medications at the SCT level include albumin, the protein, dextran, which is and hetastarch, which are both from the military and are blood expanders. And then all blood products are considered SCT level, keeping in mind that we should never initiate blood therapy, nor should we take the patient from the sending facility for at least 15 minutes after a blood transfusion is started, whether it be whole blood, packed red blood cells, fresh frozen plasma, any components involved. We'll have a whole section on blood therapy later on in the program. A couple other random drugs. All antihistamines can be transported by a routine paramedic, whether it be an IV Benadryl or something newer. Also, Nasiritide is an SCT drug, which was great for decompensated heart failure, but there's some recent studies showing that it's actually not effective, and it does not lead to any increase or decrease in mortality. There's some lawsuits pending with the FDA about this. And also one random drug is Protonix. It's a proton pump inhibitor that helps reduce the symptoms of gastroesophageal reflux disorder. So this one can be transported by an SCT paramedic. I hope this gave you a good review of the drugs that can be transported by a routine paramedic and by an SCT qualified paramedic. During the next few lectures, we'll look at which drugs are used with which medical complaint and condition and how they should be administered. This completes this segment of the training.